Hi, thank you, Dr. Pash, for the kind and beautiful introduction. My name is Dr. Liza Smigel. I'm a physiatrist. I am the medical director of the Hawaii Center for Regenerative Medicine. And I would like to thank Dr. Jim DeCastro for inviting me to present with a prestigious group of masters in their field on Pains and Needles, this virtual conference held May 1st, 2022. My topic will be on Dextrose Perineural injection treatment of the lumbar spine, including Dextrose Caudal epidural. I have no financial disclosures. We all know that back pain is a common and debilitating disease. In total, 40% of the population suffers from low back pain during their lifetime. It is the #1 cause of disability worldwide, which affects people's ability to work and function, which surpasses every other condition. Despite its prevalence, back pain causation remains unclear. In 80 to 95% of cases, it is not possible to identify a pathological cause of low back pain. There are many structures that can be injured or affected to cause back pain, such as the list here. But even with the use of imaging, majority of back pain is referred to as nonspecific with no definitive cause. So why is back pain etiology so elusive? Today, I will focus on neuropathic pain syndromes. A new phenomenon that has been overlooked as a cause, but is now really taking pain world by the storm, is that back pain is caused by entrapment or compression of cutaneous branches of the dorsal ramus that supply the thoracolumbar fascia. These are subserved from the spinal levels, lower thoracic, T10, T11, T12, upper lumbar, L1, L2, L3, and sacral, S1, S2, S3. This phenomenon is now called posterior cutaneous entrapment syndrome, or POCNES. Since the introduction of PIT 15 years ago, as a very successful treatment for neurogenic inflammation, this phenomenon has really taken root as a first line and simple treatment for patients with back pain who would otherwise remain burdened by their pain. This is the anatomical field of the thoracolumbar fascia. Another syndrome that I will be speaking about is the sinovertebral neuropathic pain syndrome that can present as discitis or the formation of degenerative disc disease. What is PIT? PIT stands for Perineural injection treatment, which is a near nerve injection technique using 5% isotonic dextrose in sterile water without anesthetic that provides instant relief and with repeated treatments have a cumulative effect. Other names for it is neuroprolotherapy, which is still used in many other countries, or the lift-off technique. I would like to just talk briefly about ion channels. So how do nerves go wrong and produce neuropathic pain? So these are the ion channels that have been discovered by neuroscientists that are found on nociceptive membranes. And the direct activation of most of these channels is triggered by changes in voltage via sodium, potassium, and calcium. And I will speak to you about the TRPV1 channel and the K2 potassium channel. So TRPV1 is transient receptor potential valenoid 1. It is now thought to be responsible for neurogenic inflammation. TRPV1 is sensitive to mechanical injuries, noxious heat, endogenous pro-inflammatory molecules such as arachidonic acid, metabolites, nerve growth factors, bradykinins, and tissue acidification of any cause. When TRPV1 ion channel is activated, there is an influx of sodium and potassium into the cells. Sodium influx causes depolarization of the membrane, potential producing pain, and calcium influx causes the release of neuropeptides such as substance P and CGRP from microvesicles within the cell, which starts a cascade of swelling, edema, nociceptive activation, and with chronic release, it'll produce degeneration and disrepair. This requires a lot of energy and glucose for ATP. We now know that brain and peripheral nerves are known to be high energy users and needs constant requirement of glucose. And the persistent opening of the TRPV1 ion channel is strongly associated with persistence of chronic neuropathic pain. So the hypothesis is that C fibers become hypoglycemic due to repeated firing of electrical signals, depleting energy and glucose. So how is pain downregulated? It is downregulated by the introduction of glucose, and this is via another channel called tandem pore potassium channels, or TASC, which are co-localized by TRPV1 and respond to glucose. They are found in glucose-sensing neurons. So here is the introduction of glucose, which causes the K2 TASC ion channel to open up and get activated. There's an inflow of potassium. It inhibits neural activity, and there is reduction of pain. Furthermore, glucose is brought into the cell. It goes through the Krebs cycle, electron transport mechanism, and glycolysis. And that ATP that is produced is used to regulate gene transcription, enzyme activity, hormone secretion, and trophic and reparative activity. So these are the sensory cutaneous nerves of the low back. On the left is one of 30 cadaver dissections of the lateral branches of the dorsal rami that was studied by Dr. Robert Main. But you can see here that the main direction of these lateral branches are towards caudally, laterally, and dorsally, and pierces the thoracolumbar fascia, providing skin sensation to the region. So when you have a patient that has pain in this anatomical field, like in the flank, low back, paraspinal region, and buttock region, this is due to the changes in the fascia, such as things that don't slide well, activating the nociceptors or the sensory fibers, which can result in neuropathic pain. And on the right, you can actually predict the point of tenderness and swelling through the length of the nerve. Here are the sensory cutaneous nerves of the buttock region. This is a picture from Spaltel Holtz on the left, and the cutaneous nerves of the pelvis and buttock region. So the yellow is the CCI, or the chronic constrictive injury, or that area that you can predict that the superior cluneal nerve, which is dorsal rami from L1, L2, L3, can get caught up into those osteofibrous tunnel as it crosses the iliac crest. And they are predictably 7 to 8 centimeters from midline and travel down the mid-thigh to the posterior aspect of the trochanter to mid-thigh. The medial cluneal nerves, which are the blue dots, are from dorsal rami S1, S2, S3 and exit through the sacral foramen in the sacrum and penetrate the gluteus maximus tendon and innervate the skin of the sacroiliac joint and the lower buttocks. For the physicians who use the ultrasound, you can hydrodissect the fascial planes of the thoracolumbar fascia with dextrose for its analgesic and nutritive effect, and also to create that space to improve the mechanics. D5W is now the solution of choice in ultrasound-guided nerve hydrodissection procedures. So in this picture, you can see that the superficial layer is the dermis, and this layer here is the adipose, and these white lines are the thoracolumbar fascia. This is the left, this is the right. Under ultrasound, you can actually see the irregular thoracolumbar fascia as well as the quadratus lumborum muscles on the injured side. Here is an example of hydrodissection of the thoracolumbar fascia, targeting the sensory cutaneous nerves that traverses through them. You can see the fluid spread into the TLF and also addressing the muscles that are also affected. This allows the analgesic and nutritive effect of dextrose, as well as allowing muscles to move smoothly between. So let's now talk about the sinovertebral neuropathic pain syndrome and review the nerve supply to the disc. Here, you can see that each region of the disc is innervated by a different nerve. The posterior and posterolateral discs are innervated by the sinovertebral nerve from the ventral ramus. And the lateral disc is from the gray ramus communicans, and the anterior disc is from the afferent branches of the sympathetic trunk. You can see here also that only the outer 1/3 of the annulus is innervated, so only about 0.3 millimeter in depth. Therefore, the inner 2/3 of the annulus and the entire nucleus are completely avascular and aneural, but does obtain nutrient of oxygen and glucose via diffusion principle through the hyaline cartilage of the bony end plates. But you can also see here that the actual free nerve endings of the nociceptors of the disc are indicated in yellow dots, are more heavily distributed in the posterior and posterolateral aspect of the annulus, which means that the posterior and posterolateral aspect of the disc are much more sensitive to annular tears, as well as the area where disc herniations occur frequently. And this is observed by the sinovertebral nerve. Here's another oddity about sinovertebral nerves. It's important that nerve that innervate the posterior outer 1/3 at that level, but it is also discovered that it innervates the same distribution at the level above. For example, an L4 sinovertebral nerve innervates the posterior annulus of L3 and L4. So what does that mean? It means at the very least, there is no way the human can normally tell the difference between, for example, an L3 versus an L4 painful disc, for they are all wired together. When we talk about the nutrient of the inner disc, the vertebral end plate permits that diffusion and is the main source of nutrients such as oxygen and glucose for the disc. So discogenic back pain presents as severe achy axial pain that does not radiate to the limbs. It is very tender on depalpation of the supraspinous ligament. It worsens in standing when the disc is compressed. And modic 1 or 2 changes are found on MRI, which represents vertebral edema. So when you look at an MRI, you can see that this is T1 image and T2 image. And there's an appearance of the vertebrae that's gray and the discs, and you can see this become darker gray. So in T1, it has low signal, dark gray, and on T2, it has high signal, it turns white on that vertebral end plate. And that combination of dark on T1 and light on T2 is modic 1. And that represents edema, which is the earliest change which we can help best. Also, another thing that happens with intradisc degeneration is that the sinovertebral nerves are typically only found in a very small layer of the annulus. But when there is degeneration, the nerve fibers gradually extend to the inner layer of the annulus and even to the nucleus pulposus, which is accompanied by an expression of more substance P neurotransmitter, so more pain. I will touch on the theories of discitis are 3. 1 is Corynebacterium acne, 2, dysregulated chronic inflammation, and 3, sinovertebral neuropathic pain syndrome. When we talk about infection, Propionibacterium acne has been implicated as the cause, and it is due to a hematogenous spread to degenerative disc as low-grade subclinical infection triggered inflammatory reaction and causes those modic 1 changes, further irritating nociceptive nerve endings and inducing pain. The treatment that has been proposed is antibiotics. And this was really propagated by a study that was published by Albert in 2013. Antibiotic treatment in patients with chronic low back pain and vertebral bone edema, modic type 1 changes. What she did was she randomized to 2 groups, either 100 days of antibiotic treatment with bioclavin or a placebo, and they were blindly evaluated at baseline, at the end of 100 days, and at 1-year follow-up. The results show that the antibiotic group improved highly statistically on all outcome measures and improved continued for 100 days until 1 year. So the conclusion, the antibiotic protocol in this study was significantly more effective for this group than placebo in all primary and secondary outcomes. But there are now studies that disproved or refute antibiotic recommendation. These 3 studies were all published in 2019 from Sweden, Denmark, and Norway independently. And one study was authored by Fitzel on bacteria and disc. He compared surgical samples from both degenerative disc and non-degenerative disc and analyzed for bacteria. He did not see any statistically significant difference in bacterial presence in each group, and his conclusion was that the findings of bacteria are most likely contamination during surgical procedure. The second study was UGDI, where they evaluated modic changes and back pain and found that modic changes with back pain were not negatively associated with back pain or function after 13 years. The last study was published in 2019 also, was by Bratton, where he reproduced Albert's study design, double-blind, multi-centered. They treated the patients with amoxicillin for 3 months and placebo, and they did not see any relevant clinical effect after 1 year in patients with back pain and modic changes. So based on these 3 studies, antibiotic treatment with no serious signs of infection cannot be recommended. And it's important to consider this to counteract the development of antibiotic resistance. So the second theory is dysregulated chronic inflammation. And this is really well studied because what really happens inside the disc, there's degradation of the extracellular matrix, there's dehydration, there's less of viscoelastic function, and you see more end plate marrow changes as evidenced by modic changes. So what happens in there? There seems to be an increase in inflammatory molecules such as tumor necrosis factor A, interleukin 1, interleukin 6, and there are improper cytokines being released, causing the wrong type of immune cells with inhibition of good pathways that promote degeneration of the disc. So when you have an injury to the disc, it also injures the surrounding vertebrae, seen as modic changes. And the treatment should focus on healing with the least metabolic dysregulation. So there are molecules under investigation to target inflammation and discogenic pain, like tumor necrosis factor A inhibitors, IL-1 inhibitors, nerve growth factor inhibitors, even PRP, melatonin, resveratrol, to name a few. And the ones that are really getting attention are these cutting-edge, very esoteric treatments using stem cell or exosomes to heal with autologous stem cells for regeneration with the least scarring and healthy repair. Many of these are case reports. Only a very few regenerative clinics can perform these. Research grants and IRB are needed to perform these. They're not very accessible to our patients that we see on a daily basis. They're not covered by insurance and are fee-for-service that can run thousands of dollars for treatment. So there are a few studies that support it, published by Baccarat in 2019 and Patine 2015, 2016, 2017, where he followed them for at least 3 years. And the recent one by Hu, the last one, using exosomes injected in intra-disc as well as intraosseous. The last theory is saniovertebral neuropathic pain syndrome. Because dextrose caudal epidurals done weekly or biweekly is an option that relieves saniovertebral nerve pain. I will now present the dextrose caudal epidural study and the highlights of this study. This was a study where we evaluated all comers with back pain, and we were able to produce 3 different published research from this project. So we included adults ages 19 to 75 with moderate to severe non-surgical low back pain for at least 6 months with radiation to either gluteal or leg areas. We did have exclusion criteria here. So even though there was an absence of a clear guideline to classify them into subgroups, we were able to assign based on 2 sets of criteria, MRI and EMG findings with concordant with findings on clinical examination. The 3 most common diagnoses were lumbar stenosis, lumbar radiculopathy, and nonspecific low back pain. We had 4 patients with some type of failed back surgery and 2 patients with low back pain with concomitant peripheral neuropathy. The first study that was published was a double-blind, controlled, short-term analgesic effect of 5% dextrose epidural injection for chronic low back pain. This was published in February 2017. It is a single injection, double-blind study comparing dextrose without anesthetic to normal saline. And these are the results. This is a 48-hour slide. The vertical is numerical rating scale 0 to 10, and the horizontal line is time up to 48 hours. And you can see here that the blue is saline and the red is dextrose. And it shows significant analgesic effect of dextrose that endured for 48 hours, suggesting a short dextrose-specific biological activity. This is the second study. It is an efficacy study. It was published in 2018. It is an open-label study for patients with back pain. It is titled Analgesic Effect and Potential Cumulative Benefit from Caudal Epidural D5W in Consecutive Participants with Chronic Low Back Pain. The patients were given dextrose epidural, given every 2 weeks, times 4, and followed for 1 year. This is the 12-month long-term outcome, numerical rating scale, vertical line, 0 to 10, and this is a time over 12 months. And you can see that circles are when they receive the dextrose caudal epidural. And there is always significant analgesia with every injection, not seen in other studies and noted to be sustainable. And there is also a stepwise improvement during the follow-ups every 2 weeks. So this consistent pattern of post-injection analgesia suggests potential sensory neural effect of dextrose on neurogenic pain. At 1 year, the percentage of participants achieving 50% or more improvement in NRS pain score was 71%. We also followed their Oswestry Disability Index. You can see here that prior to the study, the patients were at 42.7% disability, which is lower limits of severe. By 1 year, they were at 22.5%, which is the lower limits of moderate disability. And you can also see here from this graph that most of the improvement was attained in 3 months and sustained for 1 year. The third study is the vertical small needle caudal epidural injection technique. So this is the technique study. This was published in 2016. Before I go through the results, I would like to just quickly review the sacrum and its contents. So the sacrum is composed of 5 fused bones to form a triangular bone. And there are 4 pairs of sacral foramina. The 4 corresponding sacral nerve roots exit from here. There is a paired bony prominence called cornua right here at the S5 level. And the sacral hiatus is between the cornea and is covered by the sacrococcygeal ligament. S5 and coccygeal nerves exit at the sacral hiatus, and penetration of the sacrococcygeal ligament provides the access to the epidural space. The coccyx is inferior to the sacrum, and the tip of the coccyx is an important landmark. You can see the dural sac ends at S3 and the venous plexus end about S4 and is concentrated in the anterior portion of the canal. The remainder of the canal is filled with fat. The advantage of the caudal epidural is that even in the heaviest patient, the sacral hiatus can be identified easily, which is at S5. The dural sac does not extend beyond S3, which is less risk for dural puncture. And because the entry is distal to pathology, access can be obtained safely without influence of adhesions. And you can address multiple spinal levels with one site, which is what we see in many cases of lumbar stenosis. And that systemic reviews confirm effectiveness superior to interlaminar epidural injections. I use the vertical caudal technique placement through the sacrococcygeal ligament. This was taught to me by my mentor and colleague, Dr. Howie Rosen, who already passed away. And the advantages is that it further reduces the risk of dural puncture and injury to the venous plexus. It is more comfortable for the patient, and it is an easier, simpler technique because you can use a shorter, thinner needle. When you want to do a landmark-based caudal epidural, you can use the tip of the third finger technique. Basically, you line the third finger with the tip of the coccyx, lay it down flat on the sacrum, and the sacral hiatus is in line with the proximal interphalangeal joint crease with a size 7 hand. If you have a larger glove, like a size 8 or 9, then the line of the sacral hiatus would be distal to the crease of the PIP. If you have a smaller glove hand, like a size 6, then it would be more proximal to the PIP crease. And here you simply direct the 25 gauge, 1.5 inch needle directly vertical or perpendicular to the skin of the sacral hiatus. So basically it would look like this. Those little dots are the cornua or the bony prominences, and you can direct the needle vertically between the cornua. So this is a correct placement. The red would be the vertical technique. If it was unsuccessful, then you can see that the radio-opaque dye would be outside the epidural space. So the vertical technique is to see if this is technically feasible. And our method was we localize the sacral hiatus, we pop and drop, we inject a dye to obtain epidurogram pattern under fluoroscopy. We count the number of miss rates on first entry, and we also count the number of blood return. And the findings were that out of 199 epidural injections, 179 were successful. That's a 90% success rate. And there was only 1 out of 199 that showed some blood return. So for the ultrasound-guided caudal epidural, it's actually quick and easy, and it guarantees that the injectate has been delivered to correct location, 100% accurate with image confirmation. You scan inferiorly until you see the prominent cornua on each side. You visualize the sacrococcygeal ligament and the epidural space. I typically just go vertical or out of plane technique, pop and drop, aspirate if you want to.
Take your third finger and you're going to line it up to the tip of his coccyx. So you have to find the tip of the coccyx and you lay it down. And the sacral hiatus should be right in line with your PIP, which your knee is right here. And because I have a smaller hand than a size 7, it's a little bit more proximal. So then you check for those bony prominence on each side, which is the cornea, and I can feel it here and here. I'm going to draw a line in that region. Okay, so right in between that is a divot, which is the sacral hiatus. Okay.
After you sterilize the skin and put a sterile drape, you can choose to numb the area with a lidocaine solution.
Okay, so now you're going to put your finger in between and with a bevel up, go directly, basically perpendicular, and then you feel a drop. You see.
The pop and drop is very subtle. The pressure when you're pushing fluid is easy and very little discomfort for the patient. Here, I'm taking a linear probe, trying to visualize the cornua on each side. You will see it like this on ultrasound. You'll see the sacrococcygeal ligament above and the epidural space below. I typically just go out of plane, pop and drop, and then aspirate. And usually when you're pushing fluid, you will see some fluid going under that ligament like this, and you're already in the epidural space. Treating with PIT and Dextrose caudal epidural has already changed the treatment protocol for low back pain and radiculopathy in many parts of the world. It is becoming the solution of choice for ultrasound nerve hydrodissection. It is used in synergy with PRP and stem cell treatments. It is within reach of common people. It is simple, safe, and effective. It really does help a lot of patients that need us. We still have a lot of research to do. Thank you so much for your attention.